Hi, it's Dr. Robert Seichert. Welcome to episode 16 of Doctor Podcasts. And today I'm really pleased to have as one of my guests, a giant in both ophthalmology and medical education, Dr. Carmen Puliafito. Dr. Puliafito and his inventor colleagues were responsible for creating an incredibly important new technology in the early 1990s called OCT, or optical coherence tomography. If you've had an eye exam in the last 10 or 15 years, most likely you have been imaged by this technology called OCT. OCT has imaged approximately 30 million people over the years. It's helped us to diagnose diseases of the eye and the retina and optic nerve in a very early phase and has literally saved the vision of millions of people. So, Carmen, thanks very much for coming today. I really appreciate you taking the time to do this. I know you got your start at Harvard and MIT up in the Boston area. Can you tell us about that, how you got started and how you got there?
Well, I grew up in Buffalo, New York,
Oh, okay.
and I spent the first 21 years of my academic career at Harvard. I was there as an undergraduate, as a medical student, and as a resident. When I was a resident, I was interested in going into academic ophthalmology. And when I was a senior resident, I was searching for a topic to study and to be an expert in. And I went to the American Academy of Ophthalmology meeting in 1981. And there were rumors of a great laser system for cutting membranes in the eye, the ND-YAG laser, which was not shown at the Academy and was barely shown in the United States. And I decided to become an expert in lasers.
So that's how you got started. And eventually you and your colleagues up at Harvard and MIT came up with this OCT, optical coherence tomography. Can you tell us about that, how that happened?
Well, the strategy that I had was to collaborate with basic scientists at MIT. And this is a tremendous resource. And I went to MIT and went to physicists and asked them, would you be willing to work with me on lasers in the eye? And one of them, Eric Ippen, a senior professor, said, I've got a graduate student who might be interested in doing this, Jim Fujimoto. And Jim and I began a collaboration that has lasted 30 years. And what he brought to the table was an extraordinary expertise in optics, optoelectronics, and he came to understand the clinical problems that we were dealing with in ophthalmology. And together, we were able to develop this technology, OCT.
Which allows us to image the retina and the back of the eye, the optic nerve, with a high degree of magnification and resolution so that we could see disease processes very early on.
Right. We can see common diseases like diabetic eye disease, diabetic retinopathy, and macular degeneration. OCT is essential in diagnosing these diseases and coming up with strategies to treat patients. And OCT has now expanded into fields like gynecology, cardiology. It's being used to analyze pathologic specimens. So it's a very powerful tool.
Right. The other great thing about OCT, just for the audience, is there's no X-rays or radiation involved in OCT imaging, unlike CAT scans and X-rays. So it's very safe. There's no risk to OCT imaging.
It's low-level light.
Right. The way I explain it to patients sometimes is they're more familiar with ultrasound, which is using sound waves to basically analyze tissues. This uses light waves. And by doing that, it allows us to image things with very high magnification and high resolution.
Yes. And usually we're using invisible light to do this.
Right. Wavelengths that we can't really see.
Yes.
It's pretty amazing because when I was a resident and in training, we used to look at the retina with an ophthalmoscope, and it would give us a pretty reasonable view, but we couldn't see things down to a microscopic level. And now with OCT, it's almost like looking at pathology specimens in a laboratory under a microscope with 100 power magnification. So it's really pretty incredible. Now, after your OCT career, you went on to work at the New England Medical Center and Tufts, and you were chairman of the board there, I believe, and also the head of the ophthalmology department. Can you tell us how that evolved?
Well, I was recruited from Harvard to go to Tufts, which had an extremely small ophthalmology department with only 3 or 4 faculty members. And my mission was to create a new eye institute. And I called it the New England Eye Center. And Boston is a very competitive medical town.
Right.
And we created a major institution with 30 faculty members and a substantial research program, which continues on to this day. And I spent 10 years there running the Eye Center.
Right. Were the people at Harvard annoyed with you that you went across town and were competing with them?
Yes. I mean, there's a lot of institutional rivalry in Boston.
Right. But still, you managed to create this incredible department there. And then you said you were there for about 10 years or so, right?
Yes. I was chairman of the board of the medical board at New England Medical Center, which is now called Tufts Medical Center. And I was chairman during a period of time of great stress. It was in the mid-1990s, and the Mass General and Brigham, the two largest academic medical centers combined into one, had tremendous market power, and we lost our contract with a major HMO, then known as Pilgrim Healthcare. And so the New England Medical Center had real financial problems. And we were on the verge of selling ourselves to Rick Scott and Health HCA, Columbia HCA. And interestingly, I had a patient Bruce Celia, who is a federal judge and chairman of the board of an integrated healthcare system in Rhode Island, Lifespan, which had Rhode Island Hospital and Miriam Hospital, and was a major force there, and got him interested in partnering with New England Medical Center. So New England Medical Center was essentially rescued from becoming a for-profit hospital through a merger with Lifespan, and I helped orchestrate that.
Wow, that's an amazing accomplishment. So, but you didn't stay there beyond the 10 years. You then moved on to the Bascom Palmer Eye Institute and University of Miami, right?
Yes.
In Florida. Why'd you do that if you were being very successful at Tufts and creating this major eye institute?
Well, I was one of the things that's been a common thread in my career is I've been interested in building institutions and helping institutions that needed transitioning to a higher level of performance. And Bascom Palmer is one of the great ophthalmologic institutions in the world. At that time, it was ranked number 2 at U.S. News and World Report, but it had some organizational and leadership issues. So I looked at this as, and there was a hunger for change and building, and I thought it would be an attractive place to go for that.
Sounds like you like challenges.
I like academic program building.
All right. Tell us what you did at Bascom Palmer, how you developed that into the #1 ophthalmology program in the entire USA. I think it's been that way for about 15 years now.
Yeah, it's been that way since I was there. I spent 3 years there, and we were eventually ranked #1 after 3 years, and it's remained #1 until this time. What did I do? I encouraged the spirit of innovation. At Bascom Palmer, we were the first to use Avastin, which is, as you know, a very powerful drug for the treatment of macular degeneration.
Right, which is also diagnosed, by the way, with the OCT machine. Prior to OCT, we really couldn't visualize the macular degeneration well.
Yeah, man, and Bascom Palmer was a tremendous center for innovation because it was the place where vitrectomy was invented and where fluorescein angiography of wet macular degeneration was pioneered by Dr. Donald Gass, but it had let itself slip. It didn't have an OCT when I got there. I
Really?
had to bring my OCT with me
On the plane?
on the plane, and so. Creating a culture of innovation and then recruiting a whole group of new faculty members and expanding the geographic reach of Bascom Palmer. We were located a single location in Miami, in downtown Miami, and I built centers in Palm Beach, in Broward County, which is Fort Lauderdale Plantation, and Naples on the west coast of Florida. So this expanded the accessibility of Bascom Palmer services. And I think what happens with a lot of academic institutions, particularly in the past, was they became very insular and were waiting for patients to come to them.
Right.
But transportation is more of an impediment to getting medical care than many physicians recognize.
So you basically expanded the institute so that it had more reach, so patients not living right near Miami were able to get the same high quality healthcare, eye care.
Yeah, I mean, I recruited a generation of clinicians that are still there today and also built the scientific base, increased the number of NIH grants greatly, got a core grant from the National Eye Institute. So I was there for about 7 years and left Bascom Palmer in great shape, and it's continued to do very well.
Right. So the people at Harvard and Mass Eye were probably happy that you left town, but what about the people at Tufts? Were they upset that you left?
Well, I think change is inevitable, and I think people understand change. I've liked every place I've been, and I've regretted leaving them, regretted leaving places. But I was succeeded by Dr. Jay Duker, who was chairman for 20 years and did a fantastic job.
Right.
He was one of my recruits.
Oh, up at Tufts.
Right.
Is he still there, or
He's moved on to an executive position in industry with iPoint Pharmaceuticals.
I see. All right. And you also expanded the research that's done at Bascom Palmer, right?
Yes. Yes. We recruited probably 10 scientists.
So you've got a lot of grants you mentioned from the NIH and so on. And
right.
Once you created that incredible eye institute, which has been #1 for many, many years, you then decided to move on to California, and you became the dean of the Keck Medical School there at the University of Southern California. Can you tell us why you did that and what you wanted to accomplish there?
The medical school at USC had received a $110 million grant from the Keck Foundation about 4 years before I arrived. And they were poised to grow, and they were looking for new leadership to provide new direction and to provide a reincarnation of the medical school, so to speak.
Right.
And the opportunity was considerable, and I decided to take a chance and do it.
All right. So tell us about some of the major accomplishments while you were there.
Well, one of the things that I'm happiest about and proudest about in my career is that I've been able to recruit wonderful people to every institution I was at. And at USC, I was able to recruit the leaders of about 10 clinical departments and the head of our stem cell institute, head of our neurogenetics institute. The top 3 research scientists at USC, Paul Thompson, Arthur Toga, and Andy McMahon, are 3 people that I recruited. We raised almost $1 billion for programs.
$1
billion.
Wow.
Yes, we got another $220 million from the Keck Foundation, and so it was an opportunity to build, and I was there for about 8.5, 9 years.
Wow, that's an incredible accomplishment. Now, did you also practice ophthalmology and see patients while you were dean
I
of,
did.
of
I
the
did it.
medical school?
Yes, I did it 2 times a month.
Okay. And your specialty is in the area of retina?
Yes, I'm a retina specialist. So had an interest in macular degeneration, diabetic retinopathy in particular.
Right. And OCT imaging.
Right.
And OCT imaging has evolved. You mentioned that it's now used in other specialties, especially cardiology, OBGYN, and so on. In the last few years, there's something called OCTA or OCT angiography that's basically evolved from what you started. Can you tell us a little bit about that and what the significance of that is?
Well, one of the things with the first generation of OCT, we could get optical sections. It's really made an optical biopsy of the retina. And the retina has about 10 layers. So it's a multi-layered structure. So we could get great pictures. With OCT angiography, and angiography means measuring blood flow, angio meaning vessel, we're able to look at blood flow in the retina. And blood flow in the retina is abnormal in diabetic retinopathy and macular degeneration. So this has proved to be a very powerful tool. And I did some of the earliest work with OCT angiography.
Right. Prior to that, you'd have to inject a fluorescein injection into a patient's arm and then watch this fluorescein dye go through the blood vessels. So this is a less invasive way to visualize the blood vessel flow in the retina and other layers of the eye. That's pretty amazing. After you left that position, you've now been involved in several research projects and several companies and educational companies as well. Can you tell us what you've been doing since then and consulting?
Yes, I've done a lot of consulting, worked with industry, looking at how to translate technologies and their application into the clinic. And that was an important part of OCT. Because one of the things we did with OCT is we created a startup called Advanced Ophthalmic Devices. And we created a commercial entity to build OCTs and to develop it, which we eventually sold to Carl Zeiss Meditech in Germany. And so I continued to consult with drug companies about optimal ways of using drugs for treating diseases like macular degeneration. And I did educational consulting about running educational programs for doctors.
Right. We spoke earlier. You mentioned you also have your own podcast, I believe.
Yes.
Right? Tell us about that.
I have a podcast called Retina Synthesis, and it is directed toward retina specialists. There are about 3,000 retina specialists in the United States. We publish weekly, and we look at new drugs for treating retinal problems. And you might think that's a small area, but there are literally hundreds of drugs being studied, being considered for treatment of diseases like macular degeneration and diabetic retinopathy. And the reason why that is that the number of patients with diabetic retinopathy is expanding rapidly because diabetes is a global epidemic.
Right.
And macular degeneration occurs typically in patients in their mid 70s and 80s and 90s. And that is the most rapidly growing part of the population. So there's tremendous need for better strategies for treating these disorders. So there's all kinds of interesting basic scientist work that goes all the way from gene therapy to specialized drugs that last longer in the eye. And so we bring experts, thought experts together every week, and we interview them and get this information out to the retina community.
Right. It's difficult to get a new drug approved. You have to do a lot of basic science research and then do clinical trials, which take years and hundreds of millions of dollars, and then get FDA approval. So
Yeah.
you're working with some of these people to try to get new and better drugs.
Yes. I mean, uh, for instance, gene therapy has been studied for wet macular degeneration probably for about the last 5 years. And right now there's a pivotal trial looking at that. And that's probably, we're probably 3 to 5 years away before that reaching clinical uh, utilization. But the field is never going to end. What we see
Right.
now is a horizon that's filled with opportunities to improve the care of patients with vision problems. I mean, it's an exciting time to be working in vision research and bringing products to market, bringing products so that the practicing doctor and patients have access to them.
Right. You mentioned gene therapy. Are there any trials of using the mRNA type of vaccine technology to help with retina problems and other eye problems?
There's an mRNA. There's no vaccine work that I'm aware of with retina, but there are uh, scientific approaches using mRNA for treating macular degeneration.
What about using adenovirus variants to inject genes into the retina for
Very,
certain genetic diseases?
very common.
Very
Very
common.
common. All the gene therapies use the adenovirus as the vector for bringing in the new gene, and we're getting better. There's some exciting new technology about this. The eye is ideal for gene therapy because it is isolated from an immune response.
Right.
And every one of the gene therapies has some immune response, but some of the newer gene therapies have a very minimal immune response. So I'm convinced that gene therapy is going to be a major part of ophthalmic therapy within the decade.
Yeah, it seems to be that way, especially with the CRISPR technology on top of that, which allows you to edit genes. So
Yes.
if you find a genetic defect, you could potentially use an adenovirus to inject the corrected gene or the healthy gene into somebody with a genetic defect.
Yeah, we're right at the beginning of this.
Right. Takes time to do that. You also mentioned you're involved in some educational companies and
Yes.
consulting as well. So that's very important. On this topic, it leads us to the discussion of AI. I ask all my guests about artificial intelligence. What do you think the role of artificial intelligence is in ophthalmology now, and where do you think it's headed in the next few years?
Well, I think artificial intelligence is going to be a huge part of ophthalmology. I think already we do lots of imaging
Right.
for diabetes, for macular degeneration, and there are going to be algorithms that are going to be developed and implemented by AI to assess patients and to come up with treatment strategies. That's clear cut. And I think, just to bring OCT back into the picture, OCT is an automated examination of the retina.
Right.
And what you're going to see with a lot of medicine, and including ophthalmology, is that there's going to be a lot more remote diagnosis, minimally invasive remote diagnosis, so that the ophthalmologist is really going to be more like a pilot with all kinds of information available.
Right.
And this will make the examination easier for the patient and more productive. But it's hard to see that AI won't have a tremendous impact. It's not going to cut the number of ophthalmologists that we need down because we have a shortage of specialists. And in the end, you're still going to need a clinician to make the final decisions about what to do.
Do you think we'll ever get to a point where a patient comes to an office or a clinic and tells a computer what their problem is, their chief complaint, their vision issue, their eye issue? The machine then scans the patient's eye, does the exam, comes up with a diagnosis and treatment, and maybe the ophthalmologist is just the one who injects medications or does the surgery? Is that where it's headed? And will patients accept having a computer as their doctor?
I think it will elevate the standard of care, and I think it's coming. I think the clinicians, the doctor-patient relationship is still core to medicine,
Right.
and I don't think that's going to go away. But the mechanisms by which we evaluate patients and make clinical decisions will improve, be
Right.
better informed.
My fear sometimes is with all this artificial intelligence in medicine, there's a risk of it being hacked, just like we have people who are hacking now and causing all sorts of trouble in finance and other companies. There's possibility of hacking in AI healthcare, and what happens when that occurs? Who's responsible? Who does the patient go to if there's been some hacking and the wrong treatment is prescribed or other problems like that?
Well, I think it's definitely a challenge, and I'm not aware that I'm not aware of instances of hacking in artificial intelligence. And of course, artificial intelligence right now in medicine is very small.
Right. It's still small, but it's growing fast,
Yes.
and people like Elon Musk, are fearful that we may get into complications and problems with that, and the machines take over. You don't think that's going to happen?
No.
So ultimately, it will be a good thing. That's good. Now, you also have, in addition to being a physician and researcher, educator, you also have an MBA degree.
Yes.
When did you get that, and how has that helped you in your career?
I got that in my mid 40s while I was chairman at Tufts, and it helped me understand management challenges at my positions at Miami and in California.
Right. So it helped you with the business aspects of
Yes.
medicine and growing these centers. Do you recommend that doctors get MBAs to help them with that?
I think it's helpful for
It
the
is.
right. If you're interested, um, it's useful.
Right. And since you're an expert in healthcare, in many aspects of healthcare and different positions that you've had, we've all heard that the healthcare system is broken, from patients and doctors and politicians and administrators and regulators. What's your thinking on that, and how do you think we can fix a lot of the problems you have? And is it fixable? Are we just such a huge country with so many people that there are always going to be these problems?
Well, I think there are two sets of problems. One is a public health problem, which is taking care of common diseases, prevention of serious diseases, things like hypertension, obesity, uh, cardiac disease, public health challenges, vaccines,
Right.
vaccinations. And then the other two issues are access to care and finance. If you, we have a wonderful technologies and treatments in medicine in the United States,
Right.
but they're not available to everyone. And and many individuals have a tremendous problem accessing them, either because of financial reasons or because lack of being plugged into the system.
Right. They're just not aware of what's available, the knowledge and experience information. How do you fix that? That's a huge problem. Many
Uh,
of my patients, for example, have no idea what diabetes is. Even though they have it, they don't know what their A1C blood tests are. They don't check their blood sugars. They take medications, but don't go to the doctor for a year or two. How do we fix that kind of a problem?
Well, I think we need to have better science, basic science education in the high schools. I mean,
It's got to start early.
so basic concepts about what constitutes good health and creating some confidence in the public that medicine and science can be helpful rather than coming up there are lots of alternative modalities that are not medical or scientifically based that people are interested in. So confidence in medicine as a scientific field needs to be out there.
Right. And I don't think it's taught currently in schools. And by the time you're in your 20s or 30s or 40s and start getting these chronic diseases, it's a little too late.
Mm-hmm.
And we're playing catch up. And that's why healthcare is so expensive. That's a
And
problem.
we need access to care, which is a financial issue. And we need a more universal access to healthcare. We've improved a lot in the last 15 years with access to care, but we need to continue working on it.
Right. Still a lot more to go. So, finally, what's your advice to young physicians who are just starting out, and what would you recommend to make their careers even better in the future and to help society?
Well, I think that in terms of medical practice, uh, physicians should understand the economics of medical practice better. What it means to be in a group, what it means to be employed by an HMO, what it means to be employed by a for-profit organization, so they understand the incentives that everyone has for their performance. So I think that's one thing.
They don't teach us that in medical school.
No, and it can be a source of unhappiness. When I was dean at USC, I actually had a group of students that I had taken an online course in accounting, which was a way of getting them to understand basic financial issues. So understand the sociology and economics of healthcare if you can. And you can take some specialized courses. There are seminars, there are lectures. And if you're truly interested, you can get an M.B.A., but I'm not recommending that for everyone.
Right.
So that's one thing. I think if you're interested in new technologies and research, and this is mainly for people who were interested in academics, reach out to basic scientists, to engineers. If you've got a good idea, pursue it. It might do very well for you. Okay. And pick a specialty that you love.
Right. Then it's not a job, it's something you enjoy doing every day. Well, that's great advice. Really, really good advice. Thanks very much for that. Well, it's been a pleasure speaking with you today. Thank you very much for taking the time to come here. It's been a delight to see you, and thank you very much.
Thank you, Robert.
All right, my pleasure.